on. We will introduce Prof later, and then we have our senior nutrition specialist, Dr. Adoma Fuku, and we also have our HOD with us, Ms. Rebecca Frimpong. So without wasting much time, let me just give a brief history of our professor before we kickstart the program. So it is a great privilege to introduce our speaker for today, Professor Jane Kalia Agios. I'm sorry if the pronunciation is not correct.
Very good pronunciation.
So she is a distinguished professor at the University of Malta with extensive expertise in obstetrics and gynecology, particularly in assisted reproductive technology, fertility, and pregnancy-related care. With years of clinical experience, academic leadership, and international research contributions, she has played a significant role in advancing women's health and reproductive medicine globally. Her work spans teaching, research, and clinical practice, making her for improving women's health outcome. So without taking much of your time, please join me in warmly welcome Professor Jane Kalia Agios as she shares her knowledge with us today. Professor, you are most welcome. Please, the floor is yours.
Thank you very much, Abigail. Thank you. And thank you for Dr. Adoma and Dr. Philip and all of you colleagues for giving me the opportunity to share this lecture with you. It's actually, as you probably know, the first of a series of theoretical lectures. And then I really look forward that in June, so not so long a time to wait, but in June I'll be seeing hopefully all of you in person at your hospital at the Hope Exchange in Ghana. So a little bit of an introduction. So thank you, Abigail. I'm humbled. You were very kind. But basically, just to give you a little bit of background. So, as I said, I'm Jean. I come from the University of Malta. So, by training, I'm an obstetrician and gynecologist. So, I graduated from the course of medicine and surgery way back in 1999. And this is the university where I attend and where I used to attend as a student, and now I attend also as an academic. And it's actually the hospital is part of the university. So although this is the entrance to the academic part, but if you were to cross the road, just across the road, there is the main hospital. Malta is a very small country. It is less than 500,000 inhabitants, and there is one main public university and one main public hospital, which is not only the acute hospital, but also is a tertiary center. There are, of course, all over the island a number of healthcare clinics, and there are a couple of private hospitals, but the main care happens in hospital. So I graduated, as I said, in 1999, so now 27 years ago. I then went on to do research. So I didn't stick only to general gynae, but I went to research. So I read for my master's at the University of Leeds, that's in the UK. And that's me, quite some time ago, like looking much younger. And then I followed that with a PhD, which was mainly focused on early pregnancy, particularly miscarriages and even infertility. And at the same time, I was also practicing obstetrics and gynecology at the main hospital. So that's me, again, from some years ago. Then, last, I would say 10 years, basically, when I turned 40, I decided to reverse my role. So instead of being a full-time clinician and a part-time academic, I switched roles, and I'm now currently a full-time academic. I'm a full professor at the University of Malta, so back to the place where I graduated from. And then I'm also part-time clinical work. I do part-time clinical work, and that is mainly in the private practice, just because of the way the system works here in Malta. But that actually leaves me more time to do the things that I love to do. So I really love to teach, I really love to share my knowledge, and I love to learn. So please, treat these sessions not just as me, you know, imparting my knowledge to you, but please do share your knowledge, because like this we can learn from each other. As I'm sure you've been told, so as I said, this is a series of lectures. The theoretical part, there will be an assessment at the end. It will be in the form of multiple choice questions. And then the idea is that then the knowledge imparted in these theoretical lectures, they will help us to the physical hands-on training that we will be doing together in June at your hospital. And in fact, this is what we're going to be doing is very similar to another endeavor that I was involved in. This was way back in 2017, and where I ran a similar course in Tanzania in the Cardinal Rugambwa Hospital. We had run an advanced life support in obstetrics course. And at the time, we had done mostly hands-on training. But from that, I learned, together with the help of Dr. Adoma, that it would be more efficient to do the theoretical part virtually and have it recorded, and so that you can revisit it whenever you wish, and it would be, more permanent. And then we do the hands-on face-to-face when we meet in Ghana. And please do feel free to interrupt me. If you need to ask anything. Unfortunately, because I'm sharing the screen, I'm not able to see you. But and probably even if you raise your hand, I won't be able to see you. But just unmute and just ask. So please, if you need to ask any questions, please do interrupt. Okay. All right, so we're going to start from the very beginning. Now, I'm aware that a number of you are already doctors, a number of you are midwives, or nurses, or pharmacists. So it might be that, for a number of you, this is already, you already know this very well. But I think it doesn't hurt by doing a little bit of revision, especially when it comes to female reproductive physiology. Just because, since there are quite a number of hormones and factors involved, like brushing it up is always good. And I am aware that you're all very busy. Therefore, again, to spend time reading again your books is not always easy. So just having this revision lecture, I think, would be very helpful. So, reproductive physiology. So it all starts, as you know, in the hypothalamus and the pituitary. And there is such a thing as the hypothalamus pituitary gonad axis or the hypothalamus pituitary ovarian axis, which controls more or less the required physiological changes that occur both in the ovaries and in the uterus in the menstrual cycle. And when we talk of the menstrual cycle, as you probably are all aware, it's approximately 28 days, but of course, even in healthy women, it can range from 24 days to 35 days. And the way we count it, we always start from the first day of the last menstrual period, especially when it comes to calculating even gestation age. So the menstrual cycle, by default, we always say it starts with the removal of the endometrium. And that, of course, triggers the release of the follicular stimulating hormone by the anterior pituitary. So again, I know that most of you know what I'm talking about, but just to make sure that we're all starting from the same page, I'm just going to remind you where the hypothalamus and pituitary glands are. So this is a sagittal section of the human brain. And you've got the cerebrum over here with the forebrain. You've got the corpus callosum. And then there is the thalamus in this region. And underneath the thalamus, there is the hypothalamus. And the hypothalamus has a very important role in the homeostasis of our body, and also it receives information from many receptors within the brain and then transmits that information via the pituitary gland, which is this pea-sized structure at the base of the brain, that we very often remember it as the master or the conductor of the orchestra, because most of the hormones, particularly the hormones related to the menstrual cycle and to the female reproductive physiology, they start off from there. Okay? All right, so again, just to focus on the pituitary gland. And the pituitary gland, so although it's a pea-sized tiny structure at the base of the brain, it's actually made up of two parts, anterior and posterior, which are embryologically, they're of different embryological origins. And the anterior pituitary is going to be responsible for secreting a number of trophic hormones. And in the case of the posterior pituitary, although itself does not produce hormones, via the hypothalamus, it's able to secrete other hormones, like, for example, the oxytocin, for example. Right? While from the anterior pituitary, you've got hormones, you've got the luteinizing hormone, follicular stimulating hormone, prolactin, amongst others. Okay, so when we're talking of this hypothalamic pituitary gonadal axis, so as we said, I mean, there are internal and environmental stimuli which are received by the brain, and they reach the hypothalamus. The hypothalamus releases the gonadotrophin releasing hormone, also known as GnRH. Okay, it's a very important releasing hormone, which when we do infertility, we see that, I mean, it can be, that hormone can be mimicked or can be antagonized in the modulation of infertility treatment. But for today, right, just remember, so there is the GnRH, and this GnRH, in a pulsatile fashion, so that's very important, in a pulsatile fashion, it's able to send information to the anterior pituitary, which in turn, from the anterior pituitary, you get the release of the follicle stimulating hormone. So the fact that the GnRH is that will then also make the FSH and the LH be released in a pulsatile fashion, and that pulsatility will then in turn have an effect on the ovaries, okay? And the ovaries, because of the pulsatile action of FSH and LH, they're able to then start recruiting the eggs, which would have been in the ovary from as early as the intrauterine life in a female baby. But when the time comes and puberty arrives, and we'll be talking about puberty, that those eggs start becoming recruited, and at least one of them in every cycle will become mature into a Graafian follicle and lead to ovulation. So what we're going to do in the next few slides is go through that process. And again, it's important to understand that process because, of course, if we need to understand what pathologies can happen, and we'll be talking about some normal physiological mechanisms as well today, but in the future lectures we'll also be talking about pathologies. We need to understand how, at least the basic idea of how these hormones work, so that you can understand the pathology and eventually the treatment and management of the affected patient. Okay, so when we talk of the menstrual cycle, what we refer to are the three phases of the ovarian cycle as well as the three phases of the uterine cycle. So when we talk of the ovarian cycle, as we said, we start with the follicular phase, which is the recruitment of the follicles. Then that culminates in the ovulation phase, and then that's followed by the luteal phase. So those are the effects that the FSH and LH have on the ovary. While that is happening, the uterus will also be undergoing these three phases in response to the ovarian cycle. And as we said, I mean, you start the first phase with the menses, then prior to ovulation, there is the proliferative phase, and once ovulation has happened and you are in the luteal phase, the uterus, the uterine lining, is in the secretory phase, which basically, if there is no pregnancy, then the cycle returns back to menses, and then proliferative phase, and then secretory phase. So these ovarian and uterine phases, they are intimately linked together thanks to the production and release of hormones. And any disruption at this point will, of course, lead to issues. And we'll start off by understanding what happens in the normal cycle. And then, of course, when physiologically or pathologically something goes wrong, then we can understand also how to help by knowing how to modulate these three phases. Okay, so let's start with the ovarian cycle. So, as I said, the ovary as early as 4 months in utero, okay, while the female baby, the female fetus, is still in utero, already she has her reserve of eggs, right? They would still be immature. You might remember from your biology days that the eggs are, of course, are gametes, so they would have been formed by means of meiosis, right? But out of these eggs, there will be, they would start their first phase of meiosis, all right, or this division, this division of chromosomes as early as 4 months, while still the fetus is in utero. And they remain in that phase, like what we call the first phase of meiosis 1. They remain at that stage, like in suspended animation, till it's time for puberty to start. And then with every cycle from puberty until menopause, what I'm going to describe, it's a cycle which happens, every time. And once we run out of eggs, once a woman runs out of eggs, then that's when she enters menopause. So let's take a normal ovarian cycle. So you start off with the FSH being released by the anterior pituitary under the action, the pulsatile action of GnRH, gonadotrophin-releasing hormone, that is coming from the hypothalamus, and that starts recruiting the eggs, or let's say the egg, which is going to be released that in that particular cycle. So if you were to do an ultrasound from the start of the menstrual cycle, initially these eggs, they wouldn't be visible. But as you start progressing along the menstrual cycle, right, and you start reaching, for example, day 9 from the start of the menstrual period, you start seeing the eggs which start becoming visible on ultrasound, and that's because these eggs, they start developing an antrum, right? In fact, we call them antral follicles. They would be visible by ultrasound. And then, under the effect of LH, which is usually triggered, literally, it's a spike of LH, which happens about 36 hours prior to ovulation, okay? That LH will make that follicle become bigger because the antrum becomes even bigger, and that becomes called the Graafian follicle. So within 36 hours of the LH spike or the LH trigger, that Graafian follicle is about to be released, And as these follicles are forming, in particularly when the Graafian follicle is about to be released, these follicles are able to secrete estrogen. Okay, and that estrogen, which is coming therefore from the follicles within the ovary, that goes via the blood and has an effect on the uterine lining, as well, of course, it's circulating on all the body. So, 6 hours of the trigger by the luteinizing hormone. The luteinizing hormone, remember, is also coming from the anterior pituitary. The Graafian follicle ruptures, the egg is released, the egg is collected by the fallopian tube of the uterus, okay? And what remains of the Graafian follicle becomes called the corpus luteum. Corpus luteum, that means the yellow body. Okay? And that corpus luteum, under the effect of LH, is now able to produce another hormone, a very important hormone, which is progesterone. Okay, and that progesterone will peak, will reach a peak about a week after the ovulation. So if we take a lady with a 28-day cycle and she has ovulated on day 14, right? So the progesterone, the peak progesterone would be around day 21, meaning that this progesterone, which of course is also being released in the blood and having an effect on the uterine lining as well as on the rest of the body, that peak progesterone would reach a peak around day 21. So if, for example, you were investigating the lady to check whether she's ovulating or not, one way to check is by measuring at day 21 progesterone, if she has a 28-day cycle, of course. Another way is, of course, also to do ultrasounds to look for these antral follicles, but that is usually then accompanied by day 21 progesterone. All right, now, just to summarize, therefore, the FSH is stimulating primary follicles, they become secondary follicles. Under the effect of LH, that secondary follicle is enlarging. In the meantime, it's secreting large levels of estrogen. And then, once ovulation occurs, then the corpus luteum is formed and progesterone is being released. And you can see that figure there. So I think this is clear to everybody, right? So, two important changes occur in women at the time of ovulation. So also, if you want to observe without doing actually any particular medical tests to check whether a woman is ovulating or not, there are changes which happen, including a change in vaginal secretions, what we call the Billings method, which becomes viscous and sticky. And the physiological reason for that is at the time of ovulation, that's when the fertile window is there, and therefore those help the sperm to find its way and to the egg during ovulation. And there is also a slight rise in body temperature, and these are helpful also when a woman is observing the time of her ovulation and her fertility window. Another important thing I wanted to say at this point is that, of course, I mean, it's true that we talk of the 28-day cycle, but as I said earlier, not everyone has a 28-day cycle and they don't have any pathology. So let's say if someone has a cycle of 35 days instead of 28 days, their ovulation will happen 2 weeks, that is 14 days before their actual period. So if you do 35 days minus 14, so it means that they're ovulating on day 21. Similarly, if someone has a very short cycle, so someone has a cycle of 21 days, for example, okay, they are not ovulating on day 14 in their case. They are ovulating on, you have to take 21 days, which is their cycle, minus 14 days, and that gives you day 7. So she's actually ovulating day 7. Now, that is very important because I'm sure you come across this as well. A number of people have problems getting pregnant just because they keep missing their fertility window. And by understanding their own cycle, and making them chart the starting day of their period and for a number of months so that you can get an average, then you can predict, when their ovulation is happening. And that is something, I mean, at least over here, many people tend to use these apps on their mobile to try to calculate when their ovulation is happening. But of course, the app is just a matter of, it's like a Google Calendar. But by actually charting a couple of periods, you can tell when ovulation is happening. And of course, if she's planning to get pregnant, that is the window of opportunity for her fertility window. Okay, so these hormones that we've talked about, which are happening as part of the ovarian cycle, these, of course, will have an effect also on the uterus. And this is where we talk of the uterine cycle. So the estrogen, which has been released by the follicles within the ovary, this estrogen will have an effect on the uterine lining, which has just been shed, at the start of this menstrual cycle, and it will proliferate. So it will rebuild the lining above the basal layer, the uterine lining. So that's what we call the proliferative phase. So rebuilding the lining which has been shed. Under the effect of progesterone, right, which, as I said, has been released by the corpus luteum after ovulation has happened, that lining becomes more secretory. So it becomes more filled with secretions, and literally it becomes more juicy and more attractive, just in case there is an embryo, in order to allow implantation. Of course, if there is no embryo, then that means that the progesterone levels will start decreasing, and that will lead to the shedding of that lining, and the menstrual phase starts all over again. Okay, so you can see the whole menstrual cycle with the ovarian cycle having an effect on the hormones, which in turn have an effect on the uterine lining. Of course, if fertilization does not occur, as I said, there will be the secondary oocyte will degenerate because it has not met a sperm. HCG is not produced, the level of progesterone falls, the endometrium is not maintained, and menstruation will happen. And as most infertility specialists will say, menstruation, I mean, for someone who's expecting a baby, they are the blood tears of a disappointed uterus. I'm sure you've heard of this before. Okay, so some terms, which again, I'm sure you're very familiar. So someone who gets no menstruation, we call it amenorrhea. You could have a primary amenorrhea, meaning that a girl still has not got her periods, and we normally expect that a girl would have started her periods more or less by age 16. So if she's older than 16 and she never had a period in her life, we say that she has primary amenorrhea. And if, on the other hand, she has regular periods, but then suddenly they stop, that becomes secondary amenorrhea. And if there is no menstruation, especially for long periods of time, so there is secondary amenorrhea for long periods of time, The commonest cause, apart from pregnancy, of course, the commonest cause would be polycystic ovarian syndrome, which over here, I mean, it's very, very common. I'm not sure what the incidence is in Ghana, but it's very common. I mean, in Malta and in Europe, particularly in Southern Europe, and prolonged amenorrhea, not because of pregnancy, but because of conditions like polycystic ovarian syndrome, which can be related also to obesity. The fact that the lining is not shed on a regular basis, there is an increased risk of endometrial cancer. And although endometrial cancer, as we will also discuss in a future lecture on cancers, endometrial cancer is usually associated more with postmenopausal women who experience postmenopausal bleeding. And we are also seeing a trend in a rise in endometrial cancer in young women and premenopausal women. And typically these would be women with prolonged periods of amenorrhea because of underlying polycystic ovarian syndrome. But we'll be talking more about that on a dedicated session on gynecological cancer. So are there any questions so far? So I don't see any hands and I don't hear anyone, so I'm going to continue. Okay, so we already know, therefore, that there is the hypothalamic pituitary gonadal excess or ovarian excess, which ultimately produces the estrogen progesterone. Now, there is a control mechanism, what we call the feedback control of hormone secretion, which most of the time it's a negative feedback. So once there is progesterone released, that will tell the hypothalamus to wait before it makes the pituitary secrete more FSH and LH, and will make the ovary wait before it ovulates again. It's meaning that, for example, if someone is still in the luteal phase, they're not ovulating yet. And more importantly, if someone is pregnant, the negative feedback will make the woman stop ovulating during pregnancy because you don't want to waste eggs, right? Okay, so what happens if there is actually fertilization? So what happens if the egg, which has been released during ovulation, manages to meet the sperm and there is fertilization? So the first part, of the luteal phase starts off similarly. So you have the rise in progesterone accompanied by a rise in estrogen, like it's a more modest rise in estrogen, it's mainly progesterone, and the lining is in the secretory phase. But once there is implantation, and as you know, implantation is usually on day 5, with day 5 meaning like day 5 after fertilization. Why? Because although fertilization would happen usually within, the maximum 24 hours of ovulation, the fertilization is happening in the fallopian tube. So it takes approximately 5 days for the embryo to move from the fallopian tube towards the uterine cavity, by which time the embryo becomes the blastocyst, and then implantation would happen by day 5 after fertilization, or day 5 of the embryo. Once that happens, although the woman wouldn't know yet that she's pregnant, but by then there will be the release of a new hormone, which is now being released by the embryo, specifically by the outer layer, the trophoblast of the embryo, more specifically the syncytiotrophoblast, the very outermost layer of the embryo. And that hormone is HCG, human chorionic gonadotrophin. Okay? And human chorionic gonadotrophin that rises, it doubles basically, it doubles every 48 hours. So it rises exponentially till it plateaus by approximately 12 weeks. And that HCG will also give instructions to the corpus luteum to keep producing progesterone and actually pump out more progesterone. And that continues till about 12 weeks. In fact, the corpus luteum needs to stay there about 12 weeks gestation, and by which time, by 12 weeks, the role of producing progesterone is taken over by the placenta. And the placenta is actually derived from the trophoblast of the implanting embryo. And by then, the bulk of the progesterone then is coming from the placenta. But in the first gestation, there is the corpus luteum, which is responsible for producing the progesterone and maintaining the pregnancy. In fact, I mean, quite some time ago, a number of experiments were carried out where on pregnant animals, they were removing the corpus luteum and the, the, of course, it was ending in miscarriage because the corpus luteum is needed in order to maintain the pregnancy in humans in the first 3 months, in the first 12 weeks. So what happens if fertilization occurs? The uterine endometrium is maintained because of the release of progesterone from the corpus luteum, which is then followed by the release of HCG, human chorionic gonadotrophin, from the trophoblast, actually the syncytial trophoblast of the implanting embryo, and then the placenta starts forming, and the role of the placenta in producing progesterone is completely taken over by the end of the 12th week. So although there is some contribution from the placenta by the 7th week, but the role is taken over completely by 12 weeks. And that also explains why most women during pregnancy, they get a lot of nausea and a lot of symptoms like tiredness and constipation and, well, all the symptoms of early pregnancy around the 7th week because you've got the HCG plus the progesterone coming both from the corpus luteum and the placenta. And then the levels stabilize by the 12th week. And that's usually where most symptoms settle down. It's also important to know that the placenta will also be producing estrogen as well, to progesterone at high levels. And these, as I alluded to before, they will have a negative feedback on the GnRH. So they block the GnRH throughout the pregnancy. There is no further ovulation. There is no need to use any eggs. The estrogen is also involved in breast development, which of course is important for eventually milk production and breastfeeding. And the progesterone plays a role in the maintenance and relaxation of the uterus in order to prevent premature contractions. The placenta also produces another hormone, human placental lactogen. We don't know a lot about this, but we know that it's implicated in breast development and milk production, even though if you were to not have human placental lactogen, it doesn't seem to be disrupting in breast development or milk production. But for sure, it plays a role in fetal nutrition because it does alter the maternal glucose and fatty acid metabolism. And in fact, we'll be talking about this. There's another dedicated lecture on metabolic diseases of pregnancy, including diabetes in pregnancy, and we'll be going into more detail about that there. Of course, then, when it's time to give birth, there are also changes which allow parturition. Among the changes, I mean, these are the better known ones. There are increasing levels of CRH, corticotropin releasing hormone. The corticotropin releasing hormone, in this case, it's coming from the placenta, but keep in mind that it can also, the mother also has this in her, hypothalamus and pituitary. But in this case, coming from the placenta a few weeks prior to delivery. And in fact, early deliveries are linked to elevated CRH. CRH is also involved in the stress, the autonomic nervous system and sympathetic system and the flight fight. Okay? And during delivery, the progesterone levels drop off, the oxytocin levels. The oxytocin is other hormone, this time coming from the posterior pituitary. They rise, and there are these oxytocin receptors on the uterus, which are upregulated during gestation. And as soon as the oxytocin levels start rising during delivery, together with another hormone called inhibin, these will start relaxing the cervix and the ligaments of the pelvis. And it will allow for increased stretching of the cervix, which triggers more oxytocin, which in turn triggers more uterine contractions. And the more uterine contractions there are, the more there is stretching on the cervix. And again, it's like you enter a loop where the oxytocin will trigger stronger uterine contractions. Okay, so that is, very simply, the hormones involved during parturition. Of course, you'll find a lot of papers with many different factors, all right? But the most well-known are the fact that the progesterone levels drop off, the fact the oxytocin levels rise, and also we know that there is this inhibin, which makes the cervix and ligaments of the pelvis relax. In the meantime, there is another hormone also produced by the anterior pituitary, which normally rises to allow breastfeeding. However, it can also rise pathologically. For example, if the anterior pituitary starts enlarging and you get the prolactin-producing cells within the pituitary forming an adenoma or a prolactinoma. There are certain antipsychotics which can make the prolactin levels rise. Even stress in itself can lead to a rise in prolactin. And if that happens, and of course it's happening outside of pregnancy, it can lead to secondary amenorrhea because it inhibits the GnRH and LHFSH axis. And it can also lead to galactorrhea, that is abnormal milk production, because the person starts getting milk even though they're not pregnant. So I've come to the conclusion of the very first part of today's session. So we've covered the physiology of the menstrual cycle, so the normal physiology of the menstrual cycle. And the second part that I have included is the physiological part of the normal maternal changes during pregnancy. And then the third part will be menopause. So are there any questions up till now?
Not yet, Prof. I've not seen any questions in the chat box yet. So I'm monitoring that part for you, so you can continue. If there are any questions, I will let you.
Thank you so much. Thank you. So I'm going to proceed now with the maternal changes. So let me just open again. Okay. Okay, so maternal changes during pregnancy. So during pregnancy, there are these what we call normal physiological changes which happen, and these involve practically all systems in the body, but the ones we're going to be focusing on mostly are the cardiovascular changes, the hematological changes, respiratory, endocrine, urinary, and gastrointestinal. And we need to be aware of what these normal changes are because, of course, we need to distinguish between what is normal, physiological because of pregnancy, and when it's actually a pathological condition. And as I said, I mean, later on in this course, we'll be touching upon a number of pathological conditions. Pregnancy is usually described as a stress test for life because during pregnancy, it's very common that it kind of unveils problems, underlying problems, which might have been there and the patient was not aware of, or it might also unveil problems that will appear late in later life. So the commonest and most well-known of these is, of course, diabetes. We know that gestational diabetes, for example, carries an increased risk of getting type 2 diabetes later on in life. As I said, pregnancy in reality affects all the body, from it's basic things as weight gain, of course, the musculoskeletal, the skin, and of course the respiratory, cardiovascular, etc. So these are all normal physiological changes which happen, luckily not overnight, but over the 9 months of pregnancy. So as I said, we're going to focus on cardiovascular changes. Now, throughout pregnancy, but starting from the early days of pregnancy, the cardiovascular system has to get up to speed to meet the increased metabolic demand by the mother and, of course, the fetus that she's carrying. This means that she will be getting an increased blood volume. And the increased blood volume is not only because there is an increase in the number of red blood cells, but also because there is an increase in plasma volume. So interestingly, and it's important to keep this in mind, so although the red blood cells during pregnancy do increase in size, since there is a bigger increase in plasma volume, ultimately the mother will have a decreased hematocrit. So her blood is less concentrated and less viscous. Why? Because although her red blood cell mass increases, there's an increase in number of red cells, but at the same time, there's also a bigger increase in plasma volume. And therefore, that's why the blood is more dilute. There's a decreased hematocrit and decreased viscosity. The cardiac output meaning the stroke volume of the heart and the heart rate, it increases, all right? And as I said here, it might uncover underlying issues that the patient might have had and maybe she was not aware of. So, for example, if she had a stenotic heart lesion or there was pulmonary hypertension, it might get uncovered during pregnancy. So it was already there, but because of the increased cardiac output, her symptoms get worse. It is normal that during pregnancy there is a cardiac hypertrophy in order to be able to meet the increased cardiac output, and it's up to 50%. It is also because of this hypertrophy which happens to the heart, which is reversible. It can lead to incompetent valves, valvular incompetency, and conduction changes, which in turn, of course, this valvular incompetency can lead to flow murmurs. So this, again, keep in mind that, right, flow murmurs are common and they are innocent, meaning that they will return back to normal after the pregnancy. But please keep in mind that not all murmurs which are diagnosed in pregnancy are flow murmurs. So it's important to follow that patient up even after pregnancy, and especially if she has other symptoms which might indicate that there is an underlying valvular disease. It's important to be on the lookout for that. All right, this is just to show you the hypertrophy which happens in pregnancy. And this is from a mouse, but we know that even in humans there is an hypertrophy which happens during pregnancy, and that hypertrophy so not only affects the valves, the valve anatomy, but also the conduction on ECG. So, what are the expected cardiovascular changes in pregnancy? So, as I said, cardiac output increases by up to 50%, and it increases because the heart increases, right, by about 10 to 20%, and the stroke volume increases by about 30%. That happens because of the hypertrophy in the heart. The blood volume increases, and because of that, the mean arterial pressure, that stays more or less the same, but there is a decrease in the systemic vascular resistance, and that's why the mean arterial pressure remains the same. Of course, because of the increase in the demands, the metabolic demands, the oxygen consumption is also increased. And in fact, I'm going to also be speaking about the respiratory changes which happen during pregnancy. Okay, so the mom, her demands are about 4 mils of oxygen per kilo per minute. The fetal placenta unit needs almost 3 times as much the amount of oxygen. So basically, the mother is consuming and delivering the oxygen for both herself and the baby that she's carrying. So the cardiac output, this cardiac output starts increasing from the beginning. So by 12 weeks, by 3 months gestation, already cardiac output has increased by 35%, and for the rest of the pregnancy, it's up by 50%. During labor, there is a high increase in cardiac output, and actually, because of the what we call the aortocaval compression, and I'll come to this when we start talking about postpartum hemorrhage, the aortocaval compression and also the uterine contractions which happen just after delivery, actually cardiac output is at its highest right after delivery, meaning that, of course, it's important that even after the mother has delivered, at least the first 48 hours, she still needs to be monitored. Because, for example, and I'm sure you've experienced this, preeclampsia, although the blood pressure might have been more or less controlled, maybe with medications in the last few weeks of pregnancy, there is a risk that it becomes eclampsia in the first 48 hours of after delivery. And that's because of the rise in cardiac output. Same applies for example, cardiac lesions like pulmonary stenosis, etc., that the patient condition might deteriorate in the first 48 hours after delivery just because cardiac output is at its highest after delivery. As I said, because of the release of the aortocaval compression, that compression that the baby and womb would have been applying on the aorta and the inferior cava, and the return of blood from the uterus because of the uterine contraction, what we call the autotransfusion. This I'll be referring back to it again when we cover preeclampsia and also when we do postpartum hemorrhage. Okay, so as I said, for stenotic heart lesions and lung lesions, the highest stress because of the highest cardiac output occurs immediately after delivery. So it is important that if a mother already is aware that she has an underlying cardiac condition, or maybe in a previous pregnancy she was diagnosed with a cardiac condition, it is important to counsel her, ideally before getting pregnant. And once she gets pregnant, it's important that she is under the care of a dedicated team. Now, it can be sometimes a bit tricky in order to be able to distinguish between what is normal cardiovascularly in pregnancy and what may suggest cardiac pathology. I mean, it is normal in pregnancy to be tired, right? As I said, I mean, even the fact that the hemoglobin level goes down a bit in spite of the rise in red blood cells. But as I said, because of the bigger rise in plasma volume, it is very common to get fatigue and exertional dyspnea. What is not normal is to get chest pain or severe breathlessness or orthopnea, or cough, because of the shortness of breath, and because of course that is signifying pulmonary edema. It is common to get palpitations, but what is not normal is to get fibrillation or atrial flutter or ventricular tachycardia. It is normal to get a sinus tachycardia of up to 10 to 15%, but if it is more than that, it is suspicious. And especially, it is not normal to get a fourth heart sound and to get pulmonary edema. In pregnancy, it is normal, especially towards the end, to get edema on the lower limbs, which typically it improves, after a night's rest, but it is not normal to get pleural effusion. Hematological changes which happen during pregnancy. So following on from what we've said before, it's normal to get an increased clotting tendency during pregnancy. And that is under the influence also of hormones. So already women are at increased risk of getting thrombosis compared to men. And in pregnancy, that risk rises by at least 4 to 5 times. And the increased clotting tendency is because of the increased fibrinogen, which in turn leads to a decreased prothrombin time. There is increased platelet turnover. And another, let's say, physical risk, physical thing which puts women more at risk is that, of course, the pregnant uterus would be, let's say, putting pressure on the venous return from the legs. So it will lead to more stasis in the legs, therefore leading to DVT, putting someone at increased risk of DVT. Of course, if the mother already has an underlying condition like an acquired thrombophilia, where she's already at increased risk of getting a DVT, being pregnant does mean that she would need to have certain precautions. Again, I'll be going through that when we cover pulmonary embolism and thrombosis. Pulmonary embolism, unfortunately, like PPH, they are two major causes of maternal mortality. Respiratory changes during pregnancy. So, particular term, the maternal fetal oxygen consumption increases by up to 50% over the normal pregnant state. The airways get swollen, particularly towards the end of pregnancy. And because of the pressure by the pregnant uterus and also the pressure by the heavy breasts, there is a reduction in the functional residual capacity, which is like the air tank reserve of oxygen for the mother. There is a decrease by about 20%. So that does mean that the mother in pregnancy, particular term, does get decreased tolerance for apnea, for shortness of breath, or for hypoventilation. So you notice that patients might even have a difficulty like finishing a sentence towards the end because they're short of breath, or going up the stairs, they become very short of breath. By functional residual capacity, as I said, it's like our air tank for apnea, and in pregnancy, the air tank, which is carrying the oxygen, is much smaller than that of a pregnant woman. Therefore, there is less tolerance for apnea. And again, if you were to have a pregnant woman who is, for example, normally residing let's say, at the base of the mountain, and then she were to travel at an increased altitude, of course, because of the lack of oxygen, her symptoms will become more obvious, especially if she's not used to living at high altitude. Another important thing, the mother, because of the fact that she is overall hyperventilating to some extent. So although she's producing more CO2, because of course she's using oxygen to produce CO2, but she's blowing it off more quickly. So at term, her partial pressure of carbon dioxide is actually less. And that means that her pH, her blood pH, is slightly more alkaline. So what we call respiratory alkalosis. So she's blowing off her CO2, and therefore her pH goes up a bit, it's less acidic. And in order to compensate for that, we'll say there is respiratory alkalosis, basically, with metabolic compensation. Respiratory alkalosis because her partial pressure of carbon dioxide is slightly less because she's blowing off her CO2. So compared to the non-pregnant state, pregnant woman has less tolerance for apnea and less tolerance for acidosis. In pregnancy, there is all the mucosa, including the mucosa of the respiratory tract, is more swollen. Therefore, there are more increased risk of nosebleeds, for example, right? And similarly, because of the swelling of the mucosa, you often get women also telling you that, like, when they're brushing their teeth, for example, they bleed more. That's because the mucosa is more swollen. Changes to the endocrine system. As you can imagine, of course, there are changes. And what I'm going to talk about today is the insulin changes. And we'll go into more detail later on during the course when we talk about gestation and gestational diabetes. So pregnancy itself is described as being diabetogenic. Why? Because the placental hormones, particularly the progesterone, but even the placental lactogen, placental growth hormone, and the cortisol, they do they do behave in such a way that they mobilize the glucose stores and make more glucose available. Remember, we need glucose for our metabolism. So the insulin requirement increases during pregnancy in order to be able to metabolize that increased glucose. And after delivery, of course, it falls abruptly. Now, this is okay in someone who's not diabetic, but of course, in someone who is already diabetic, their condition does become a bit more fragile. Their diabetic control becomes a bit more brittle during pregnancy. So, gestational diabetes, as you know, it's when someone who is not diabetic, as the pregnancy proceeds, they are then diagnosed with gestational diabetes, which then disappears after giving birth. However, there is a tendency to recur in subsequent pregnancies, and later on in life, there's a tendency for type 2 diabetes. So this is where I was mentioning pregnancy being like a stress test for life. It's like uncovering and predicting any possible conditions which might arise later on in pregnancy, unless, of course, action is taken in order to, let's say, change one's diet, change one's lifestyle, etc. Gestational diabetes appears, at least here in Europe, in about 4% of pregnancies, but it can be commoner, especially if there is already a familial tendency or there is a history, for example, of polycystic ovaries. Changes to the urinary system in pregnancy. So in pregnancy, of course, the bladder sits right in front of the uterus, and the ureters are passing, behind the uterus, the pregnant uterus, And of course, because of the increased metabolism, the glomerular filtration rate does increase. That means that the normal creatinine does fall. So keep that in mind, because if you're suspecting that you might be having kidney disease, some kidney disorder, the creatinine might not rise immediately or might actually remain at normal levels just because she's excreting it. Quite common, you can get obstruction of the uterus with hydronephrosis. Tends to be temporary, because then once the woman delivers, that hydronephrosis that uterine obstruction is gone. But of course, I mean, if it's accompanied by, say, lack of drinking water and dehydration, there's increased risk of pyelonephritis. And it also can lead to formation of kidney stones, which are quite common. Renal infections do increase in incidence during pregnancy just because of the fact that the progesterone relaxes the ureters. There's compression of the ureters at the pelvic brim with obstruction and increased risk of infection. Plus, also in pregnancy, the symptoms of a urinary tract infection might not be that obvious in the beginning. I mean, just to say, for example, I mean, pregnant women, it's normal for her to have frequency, to frequently need to go to the loo and pass small amounts of urine. So in the non-pregnant state, we tend to associate that with urinary tract infection, but that's a symptom that the pregnant woman would already in her everyday life be experiencing. So by the time she actually gets symptoms like hematuria, for example, or urinary retention, already that infection might have been around for some time. And the problem is that apart from risking pyelonephritis and risking her renal function, could possibly also lead to acute renal failure. The other problem also is that it can lead to premature contractions and premature delivery. So changes to the gastrointestinal system. Gastrointestinal system under the effect of progesterone there is a decrease in the peristalsis. Again, the effect is physiological because the food stays in the intestines for longer in order to make sure that it's processed and all the nutrients are absorbed. Because of the pressure on the stomach and on the level of the cardiac sphincter, there is an increased incidence of reflux, gastroesophageal reflux, with the patient feeling like an acid sensation in the back of her throat, especially when she lies down or where she bends. And gastric emptying is impaired. I mean, we need to keep that in mind, especially if going for an emergency cesarean section. So even if the woman tells you that she hasn't eaten for a number of hours, you always have to be careful because of the delay in the gastric emptying and the risk of aspiration, especially if she's undergoing general anesthesia, total anesthesia. The musculoskeletal system, of course, with the change in the center of gravity, there is forward tilting of the neck, forward tilting of the pelvis, that can lead to low back pain, sciatica, it can be very common, and other aches and pains, which tend to be temporary. I mean, they tend to improve after pregnancy. Another common issue, for example, is carpal tunnel, especially in people who do manual work or people who are using their computers, for example. Carpal tunnel, because of the edema, which happens in the upper limbs, I mean, is very common. But in most cases, it tends to be temporary and it resolves within 6 weeks of delivery. So I've reached the next break. So I'm just going to stop sharing for a minute. Are there any questions? I don't
If
see
you have
any.
any question, you can go ahead and ask Prof now. If there are any questions, please. Is either you can raise your hand and unmute and talk, or you can type it in there. Any questions so far?
I don't see any hands.
Yes, please.
Okay, so
Yes, please.
okay, so I'm going to proceed. Okay, of our session today, I'm going to be focusing now on menarche and then on menopause, which are, of course, physiological states of our menstrual cycle. So that's why we've started today with the normal, then went to pregnancy and the physiological changes which happen during pregnancy. And now we're wrapping up again by describing the start of the menstrual cycle with menarche and the end with menopause. So menarche is the onset of the menstrual cycle. Years around the age of 11 and a half years, but it can happen precociously below age 9, and it can be delayed, and by delayed onset of puberty, what we usually refer to is after 16 years. And of course, it's not just a matter of not having a period, but even the other secondary sexual characteristics. It becomes more worrying if a girl, let's say, of 17 or 18, not only hasn't she had a period, but even she hasn't developed any of the secondary sexual characteristics and not even a growth spurt. Okay, and that's where definitely investigations would need to be set in place. Okay, so prior to puberty, so let's say when a baby girl is born, up until the age when she's getting close to her menarche, so her hypothalamus is producing GnRH, and the pituitary is producing some FSH, but the stimulation is minimal, and mostly it's minimal because the GnRH being released by the hypothalamus is not being released in a pulsatile fashion. So it is just, there is a minimal release of GnRH on a daily basis, but not in a pulsatile fashion. And therefore, the pituitary does not, since the GnRH not being received in a pulsatile fashion, the FSH being released by the pituitary and the LH, they are not being released in a pulsatile fashion. And therefore, the primary oocyte, and the granulosa cells surrounding it don't respond to the FSH and the LH until it's time for the initiation of puberty. Okay, and puberty is, a whole set of physiological changes, with menarche being one of them. All right, but as I said, there's the growth spurt, there's the appearance of the pubic hair, the development of the breast, etc., etc. But as the initiation of puberty and ultimately for the appearance of the first period, which is menarche, the LH release starts changing from being a constant minimal level to a pulsatile release. So pulsatile release of LH because the GnRH from the hypothalamus is being released in a pulsatile fashion. And we know from old experiments that have been carried out that this LH, the pulsatile LH, is especially released during sleep, which also shows the importance of children and young girls to make sure that they're getting their rest, because this pulsatility of the LH happens during sleep. Initially, these cycles are irregular and heavy. So very often, after the first period, there might be a number of months before the next period does come, and when it comes, it's irregular, it's heavy. And initially, it's because initially the cycles are anovulatory. So as I mentioned before, the HPO axis, it takes a while for the cycle, like from the hypothalamus to the pituitary. It takes a while for that cycle to follow smoothly. We also know that there is a critical fat component which is needed. We still don't understand exactly the underlying physiology of that, but what we know for sure that if someone is very underweight, their puberty is delayed, and in someone who has undergone puberty and then, for example, they start suffering from conditions like anorexia nervosa, where they start getting excessively worried about their weight and they stop eating and they start losing a lot of weight and losing a lot of fat. Their periods stop, and for them, those periods to restart, they would need to gain weight. And so we know that that critical fat component is very important. And of course, all this is associated with adrenarche, so the adrenals also play a role, and the pubarch. So that was puberty. Now let's move on to the other end of the spectrum. So after, let's say, 30 odd years of having a menstrual cycle, so a girl who started off with her menarche around the age of 11, 12, 30 years later, so as she starts approaching her mid-40s, she starts experiencing symptoms, which are usually known as climacteric or perimenopause. And that's the long transition period leading to the actual menopause. So the way I like to describe it is, so your teenage years is when you start, adapting to the menstrual cycle. And I don't know about you, but teenagers, we kind of excuse them for being teenagers, and even if they have tantrums or mood swings, etc., we just say, "Oh, they're teenagers." But in reality, when after 30 odd years of cycles, we reach our mid-40s and we start approaching the menopause. So about, at least 5 years, maybe more, before the actual menopause hits, we also enter another phase very similar to teenage years, but we're not teenagers. We're actually then middle-aged women. And while, as I said before, everyone excuses teenagers and kind of turns a blind eye whenever they have tantrums and mood swings, no one really turns a blind eye if a middle-aged woman starts, let's say, being a little bit more sensitive or irritable. But in reality, it's the same hormonal storm which is going on before the actual menopause starts. And then things start settling down. So what's the physiology? Of course, those eggs which have been there since the first few months, first 4 months in utero, and now they've reached age 45, and these eggs have been with that woman for, all those years. Those eggs become less and less responsive to the effect of FSH for a number of reasons. Because of environmental factors, diet, and even they were the eggs that the body has not wanted to use initially, but now it has to turn to them because they are the last few eggs remaining. So these are less and less responsive to FSH. It does lead, therefore, to irregular ovulation, or even if ovulation happens, there is still a decline in estrogen and progesterone. That will lead to anovulatory cycles and the period being delayed, or they are irregular, they are shorter, it skips, there is less blood. Or it could also be the other way around, that, after, let's say, months of not getting a period, then there is what we call this dysfunction, uterine bleeding, which can be heavy with clots, sometimes even leading to anemia. The similar way, there is also less testosterone, but at this point, it's a bit tricky because although her periods are irregular and many of the cycles are actually anovulatory, the woman is still capable of reproduction. So she would be at a stage where her periods are irregular, and but ovulation is still happening. Till the time comes when menopause will actually start. And that is, menopause is the permanent cessation of the menstrual cycle because of lack of ovulation. And it's basically because we run out of eggs. Now, that is something which you can diagnose retrospectively. So basically, if a woman experiences 12 continuous months without a period and she is of age 45 or above, then you know it's menopause. And in actual fact, if she gets a bleed after those 12 months of amenorrhea, then you have to investigate, because you can't say, okay, she got another period, maybe she ovulates again. It could be, but you are more likely to suspect that there is postmenopausal bleeding because of a more sinister cause. For example, endometrial polyp or endometrial hyperplasia or endometrial cancer. So that's why it's important to ask women to keep a record of their period, especially when it starts playing up. Menopause occurs more or less around 51 years of age, but it can start as early as 45 and can be, even in the mid-50s. And premature menopause is usually diagnosed when someone ends up with permanent amenorrhea before 35 years of age. And it can happen, for example, if they have undergone some chemotherapy, or they have autoimmune disease or other conditions. So menopause, so yes, it is a natural, normal physiological change which happens. It's not a disease, and it's basically the transition from a reproductive life to a non-reproductive life. And it happens because of cessation of ovulation, just because we've run out of eggs. And of course, that leads to a decreased hormonal output, particularly lack of estrogen. And that leads to symptoms like vaginal dryness, skin and bone changes, and hot flushes, being one of the commoner symptoms. So, not everyone gets the same symptoms, and not everyone gets all the symptoms, and they can come also in phases. So, hot flushes, although not everyone gets them, but probably they're one of the commonest and what patients complain most about. Again, there could be tachycardia, headaches, irritability, brain fog, memory lapses, fatigue, and even low mood. And so what's happening in menopause? So the hypothalamus is still producing GnRH and is still having an effect on the pituitary to release FSH. But because there are no eggs, in postmenopausal women, since there are no eggs, the FSH will keep rising, trying to squeeze out any possible egg. But if no eggs are there, so no eggs can be released, estrogen doesn't form, and of course, if there's no egg, there's not going to be a corpus luteum and no progesterone is there. So you don't get feedback inhibition, and therefore the FSH are very high. And that is one way that, if you want to check and confirm that after 12 months of amenorrhea, the patient is really menopausal, particularly if you're dealing with someone with premature menopause, is to check her blood FSH levels. And if they're very high after 12 months of amenorrhea, then, the likelihood is that she's in the menopause. So the estrogen is not completely zero. So if you were to take her hormone profile and measure the estrogen progesterone, they will not be completely absent, because estrogen sources include the adrenal glands, the skin, particularly fat. So we tend to see that in women who are more obese, they tend to have higher estrogen levels. And it's also produced to some extent by the muscle, by the brain, pineal gland, hair follicles. And as I said, these hormones are stored in fatty tissue. Then menopause, especially the more premature it is, it's also associated with medical conditions happening because of the lack of estrogen. And especially, as I said, in premature menopause. So the commonest of these is osteoporosis, brittle bones. So that happens because the bones calcium, they become weaker and they're more likely to get broken. And because of also the same effect on the connective tissue and on the lipid metabolism, there is also an associated risk in heart disease. So basically, women up till menopause, their estrogen, their hormones protect them from heart disease. But then after the menopause, their risk is more or less similar to that of men, because they start losing the protection from their natural hormones. So how to prevent all this? It's all education. So exercise, ideally starting from the years before the menopause, but even in menopause, a good diet, no smoking. These are basic things which, even prior to, at every point in a woman's life, it's important to keep educating about. Just a few words about heart disease. So factors that increase the incidence of heart disease, of course, are excessive weight, and that applies both to men and women. But as I said, women get the same risk as men, especially after the menopause. Consumption of saturated fats, sedentary life, smoking, and these effects are cumulative. And of course, the more we increase in age, the greater the effects. So how to manage? So HRT and phytoestrogens, again, especially HRT, it's a medical treatment which has benefits, but of course needs to be tailored to the individual's needs. And, it's given as a medicine when needed and for the symptom which is being particularly targeted. Okay, so be it vaginal dryness, there are preparations which can address that. If it is hot flushes, there are preparations which can address that. So now that many of the studies which had been done 20 years ago, they have been revisited. We have been given the go-ahead that, if used in the right doses for the right patients, there can be benefit, but we have to keep in mind that there is still medicine. And it's still important to monitor patients, especially if they decide to start HRT for breast disease and other conditions, and be on the lookout for deep vein thrombosis, etc. Exercise plays a role in the management of menopause. Okay? Of course, having a healthy lifestyle with no smoking, a balanced diet, and good sleep habits is very important. And of course, again, referring back to exercise, it's important because it's like a natural antidepressant. It helps you keep a healthy weight, mental acuity, energy, and of course, there is a lower incidence of most morbidities. And actually, that brings me to the end of my session. What you're seeing here, so first of all, grazie is the Maltese version of thank you. And what you're seeing here, you might have seen this picture before. It's actually a very ancient statuette. It's actually a very small statuette, about 20 centimeters in length of it had been recovered from one of the Neolithic temples, so from about 5,000 years before Christ. And we actually call it the goddess of fertility because archaeologists tell us that it was used as a kind of ritual in order to pray to the powers that be, to the gods, for rain and in order to have more fertile land and also to have more children. So I decided to end my session today on this because in our next lectures we'll be going through miscarriages, infertility, and problems related to pregnancy. So I thought it was appropriate to put a picture, a photo of the statuette. So thank you, and I'm not sure if there are any questions.
Thank you. Thank you very much, Prof, for the presentation. Thank you so much. And please, if there are any questions, you can raise your hand or unmute, or you can also type it in the comment section if where you are is noisy.
I'm
We
actually
just
seeing a
have
question. Actually, I'm seeing a question in the chat by Miss or Dr. Ellen Gamley, and it says,
sure, Prof, you can go ahead.
so I'm going to read them out and then I'm going to go through them. Okay, so
Yes.
one by Ellen is, so at what point do we consider early anovulatory cycles pathological rather than physiological? Yes. And the second question is, how would you distinguish normal puberty regular bleeding from a bleeding disorder in an adolescent? So very, very good questions. So let's start with the first one. So at what point do we consider early anovulatory cycles pathological rather than physiological? So really and truly, it is, there is, as far as I know, no set guideline on this. But as a rule, we normally say that when a girl starts getting her menarche, so when she gets her menarche, so let's say she got her menarche at age 11, it normally takes more or less 4 years for the cycle to become, established. So if she's 11, then by age 15, 15 to 16, she should have established a cycle. By which means that, if she gets anovulatory cycles, which, okay, I mean, if there is amenorrhea, it's usually not a big issue as long as she's not in a sexual relationship. But I mean, if on the other hand, her anovulatory cycles are giving her dysfunctional uterine bleeding with a lot of irregular bleeding, then yes, it can be an issue because she is losing blood and can become anemic. However, we usually recommend that at least up to the first 4 years from menarche, we try to avoid using hormones in order to manage the cycles. Unless, of course, I mean, she's in a sexual relationship. But so what that means is that even if she gets, let's say, a cycle which is, let's say, every 3 weeks or every 2 weeks and heavy cycles, we try to go non-hormonal. So you can't use, for example, things like tranexamic acid to control the bleeding. If she's getting prolonged amenorrhea, and maybe she has the phenotype of polycystic ovaries, you might consider metformin, but we usually wait for those 4 years. Then the second question, how would you distinguish normal puberty, regular bleeding from a bleeding disorder? Yes, that can be very tricky. And in fact, I mean, if the girl is getting prolonged heavy bleeding, and I mean, to the extent that, she's becoming anemic, yes, we do a screening then in order to rule out a bleeding disorder. Because, of course, they might be completely asymptomatic up till they start getting their period. Of course, I mean, that can lead to serious hemorrhage. Of course, you do ask about, other episodes, like, for example, if they cut a finger, I mean, whenever they go to the dentist, if they have issues with bleeding, and you become more suspicious if they already, have experienced issues in that case. But yes, then you do screen for bleeding disorders. So I'm not sure if that has answered your question. I see that you have another question. So yes, so how would you tailor menopausal management for a patient with a high cardiovascular risk or obesity? Excellent question. Yes, excellent question. So we do get quite a lot of patients with obesity here. I'm not sure what your experience is in your hospital, but we do get a problem with obesity. And yes, patients with menopause, of course, can, even though they're obese, they still can be going through issues from hot flashes to also having high cardiovascular risk. So in that case, although the patient might actually resist initially, in that case, the most important is weight loss. Okay, weight loss and control of the lipid profile. So that has to be a start, because just giving HRT, for example, to someone who is obese, I mean, is not going to solve their cardiovascular risk. So they need to seriously consider weight loss and exercise and a balanced diet, even though it's not easy, because I mean, if they've been having lack of exercise or no exercise at all, and dietary issues all their life, it was challenging to start, in their 50s. But it is a must, because otherwise just masking with HRT is, of course, not going to be of any help for them. I'm not sure if that has addressed your questions, but thank you. Very, very good questions. Let me just scroll up the chat to see if I've missed any questions. No, don't see any. Let me go down. Yes, thank you. I will be sending these presentations to the team, to the organizing team. So you have this presentation, and as you know, there is also the recording. So you'll have access to these recordings as well. And in the last slide, I mean, there is also my email. So if you want to email me, feel free. As I look forward to see you in person when I come to Ghana next month. I mean, next month. It's in June.
Yeah. Are there any questions, please? So we can go ahead. If there are any questions, kindly unmute and ask the question, or you can type it in the session, so the comment section. Um, While we wait for the questions, I just wanted to remind each and every one of our next session, which will be on the 21st of May. And we are going to be treating recurrent miscarriages and infertility. maternal and fetal immunology, just so you can keep that in mind. So that is it on the screen. Recurrent miscarriages and infertility, maternal fetal immunology. That is going to be on Thursday, 21st of May, 2026. Thank you.
Yes,
Any questions?
we on purpose have this gap because, and I wanted to start off with the physiology. So any of you who maybe needed a bit of a brushing up, we make sure that we're all on the same page, because then once we start with the other sessions, we'd kind of take it for granted that this basic knowledge, like everyone is on board with that. Then as you see, they are quite close to each other, like 21st, 22nd. So there is, they are quite close to each other.
Yeah.
And of course,
Okay.
if you think that you want me to add anything else, feel free to let me know. And I can include them, in any of these sessions. If there is anything that anyone would like to add on, we will.
Okay. If there are no more questions, then I think this is where we'll draw the curtain to the first session with Prof. So on behalf of everyone here, I would like to express our sincere gratitude to Prof. Thank you so much for this insightful session. We really appreciate this. And then to our participants, we want to say thank you for your time and your attention, and thank you for your contributions. So, my name is Abigail Dapache, and it has been a pleasure moderating this session. So, thank you all very, very much, and we hope to see you in our next session for the session 2. That is still recurrent miscarriages and infertility and maternal fetal immunology. Thank you all so much. Please, if you did not register, kindly register. The link has been posted already. Kindly register so we do not miss anybody here. Thank you all so much and have a lovely evening. Thank you so much, Prof.
Thank
Thank
you,
you.
and have a lovely evening. Thank you.